Hey there, and welcome to Concierge Medicine Radio, your source for actionable advice and real stories of physicians running and growing concierge practices. For more interviews and notes on today's show, please visit conciergemedicineradio.com and enter your email. Now, let's join your host, Taylor Pearson.
Hey guys, welcome back to another episode of Concierge Medicine Radio. I'm excited about today's interview. Just got off the phone with Dr. Jon Izbicki of Izbicki Family Medicine in Erie, Pennsylvania. Dr. Izbicki transitioned his traditional primary care practice that he'd been running for about 3 years into a direct primary care practice, a direct pay model, about 1 year ago, and has been growing that at the rate of 25 patients per month. Dr. Izbicki was strung out as a physician and feeling unsatisfied in his existing practice, and that pushed him into making the transition, and he's since felt invigorated and is really optimistic about where the practice is going. Today's show, he goes into some of the emotional details of that transition and what it was like for him and what it still is like for him as he's a year into this, going through the process of opening a new practice in a model that's not as well tested, where he's having to fill up the practice himself with his brother. He also goes into how he uses Facebook, which he says brings in 95% of the 25 new patients he's bringing in each month, and has some really good analogies he uses to explain direct primary care to patients and other members of the community. So I think you'll enjoy the show. I think the analogies in particular will be super helpful for anyone that's struggling to find ways to explain what they're doing either to their patients or other people. So without any further ado, let's get into the show. Well, tell us who you are and tell us a little bit about your practice.
Okay, sure. My name is Dr. Jonathan Izbicki. I'm in partnership with my younger brother, Dr. Harry Izbicki, in Erie, Pennsylvania. We are Erie's first insurance-free medical practice known as direct primary care. We are nearly 1 year into our conversion to the direct primary care model. At present, we have roughly just about 800 patients total in our practice. We see an average of anywhere between 3 and 7 patients a day. We schedule 30-minute appointments for all routine follow-ups, and we spend an hour with all new patients and Medicare patients, as well as yearly preventative wellness exams. We really pride ourselves in giving patients the time and being available to our folks that trust their care with us. And we really think it's a way to direct primary care is a throwback back to the way medicine used to be practiced in the age of the great doctors that were the Marcus Welby-style docs, where the patient and the doctor had a relationship. The doctor remembered their name, and the patient felt like a person, an individual, and knew that their doctor really cared for them. And I think that's what's lacking in American medicine today, that we are working for the insurance folks who basically determine what our worth is and what we're being paid. And unfortunately, running a medical practice is very expensive, and the cost to produce a doctor in the market is another big expense. But in order to make the amount of money we need in order to pay the bills every month in a medical practice, we have to see a certain number of patients. But unfortunately, insurance companies are price fixing the visits. So the only way for us to make more money is to see more volume, which means less time with the patients. And I think the direct primary care model works in a way to offset that, to go back to a previous time when, again, that patient-doctor relationship was the most important thing. And you don't have to worry about the metric of how much production there is in the office a day, rather than how much time you spent with the patient is the new metric in satisfaction.
So for other physicians or healthcare professionals listening, you said you had 800 patients. What's a full practice for you and Harry?
Okay, so most direct primary care practices across the nation shoot for roughly a target of 600 patients per doctor. So our goal would be 1,200 patients.
Okay. And then how's your pricing structured underneath that?
Oh, sure. We charge $65 a month for an individual. If it's a couple, we discount the second person at $60 a month. So in essence, a couple is $125 a month. And then any children, the first child is $10 a month, and each subsequent child is $5 a month. So we've priced this to be very affordable. So a family of 4 would cost $140 a month. I mean, that's about $4.60 a day. That's less than the price of coffee at Starbucks. So we priced it to be very affordable, and we priced it, less than actually what a cell phone bill would run for a family with a data plan.
Take us back then and kind of tell us the story of how you got to this point. So I think you said you opened your clinic 4 years ago?
Correct. Harry and I both were employed doctors at one of the local health systems, and we were part of the metric-driven animal or cattle drive, and just not meeting the production numbers that they set for us. And unfortunately, we just felt that we were kind of in a failed model of business, so we decided to move back into private practice, where we thought we could get our voice back. We could take care of people the way that we were trained to. We could honor our oath. And what we found was that after 3 years of being in private practice, which was insurance-based, we found very quickly that it's a very unsustainable model, in a large part, as I mentioned earlier, that we are price fixed by the insurance companies. They pay a fixed dollar amount for that visit, whether you deal with one problem or three problems, or even more than that oftentimes, especially with Medicare patients. They are very complex, and they do need the time. They deserve the time. But unfortunately, there's just a cost of running the business, and unfortunately, the only way to offset for rising overhead costs is to run more patients through your practice, which increases the patient wait times, and it reduces the amount of time that the doctor gets with the patient. So what we found after 3 years was that we were in a situation where we had to make a really tough call. Do we start moving into more of that cattle drive model, which we left when we were employed, or do we look at this direct primary care model? And the more we researched it, the more it made sense. So we actually made an announcement in June of 2013 that we were going to move into a direct primary care model. We sent letters out to our patients. We started our social media announcements, and we moved forward into it. And it's been a challenge, but at the same time, it's been very rewarding.
Talk a little bit more about that point where you started researching either going into a direct pay or a concierge model versus coming back into the hospital. Because I know that's something a lot of physicians are thinking about now, and I think there's a lot of emotional aspects to that decision that don't necessarily get talked about a lot.
Yeah, I agree with that. I think, anytime we make a change, it's scary. And you have to weigh the risks and the benefits just like we do in our medical decision making. But I think for a lot of docs out there, and I know that Harry and I felt this way, was that if we were going to move towards the volume-driven type of medicine, we'd be no different than we were when we were employed. Or did we go back into employment at the local health system? You almost feel like you kind of failed in a way in the private practice model. However, looking at the direct primary care practice, saying if we at least try it, we put everything into it. If it works, then we succeeded. If it doesn't, we're still back in employment. So, you have to kind of look at that and see how bad is it in your professional life that, hey, I know right now this thing is a potential risk, and I know I could lose everything. My brother and I financed our homes, and we were leveraged out to the hilt to actually start this private practice, and we stood to lose everything if this direct primary care model failed. So we understood that risk, and I know those doctors out there are saying, geez, maybe I'll go with the thing that actually is the most secure. And being an employed doctor is a very secure position, and for some people it works great. But there are a lot of docs out there that just want to have a good, solid relationship with their patients, but they're trying to find a way to make it work. And I think direct primary care is going to allow the doctors to feel that they can have practice with integrity and honor, and they can give patients what they're looking for, and they're looking for time. That's what we really need to focus on in healthcare.
So you actually you and your brother both put up your houses in order to fund the practice.
Correct.
Wow.
Yeah, that was in order to start a private practice. Now, in general, with medical students coming out, we have an enormous amount of debt, and most people don't think about that part. You have, we had about $250,000 in debt from medical school, not lost income over that time of training. And then so when you come out of residency, you have this huge amount of debt, and you're thinking, what am I going to do? I can't start a private practice. So you go with the most safe thing. You go into employment. So you get a paycheck, you maybe get some tuition reimbursement from the institution, but then you find that you have no voice, and you're being grilled by the CFO every quarter saying your PT referrals are down, doctor, your stress test referrals are down, and all those different ancillary services. And but unfortunately, if patients don't need them, you can't order them. But you'd be told, well, everybody's a little short of breath, or everybody has back pain. So you get into the ethics of it too. So it just becomes one of those type of things where employment does offer that security, but you lose your voice, and then you become indifferent. And I think the indifference in medicine is what we're seeing with a lot of docs. They just feel like they can't change it, so they just kind of have to deal with it, and they just kind of get through it. But unfortunately, doctors like myself and my brother, Dr. Josh Unber and Doug Nunemaker out at Atlas MD, and a handful of other doctors that I'm actually working with, helping them make the conversion to a direct primary care practice. These docs, we're trying to pave the way for the next generation. So, when I think about, when some people say, hey, doc, what you're doing is great, you guys are great docs for doing this. I said, great men are forged in fire, but it's the privilege of the lesser man to ignite the flame of change, no matter what the cost. So for us, we are the ones that are the lesser men. We're the ones igniting the flame of change. We're carving out the way for the next generation of docs and for patients, so we can get back to what medicine is about. It's what most of us signed up for when we applied to medical schools. So I understand the risk, but you have to weigh the risk versus benefit. And when things are bad enough, the risk actually seems to be worth it. So that's where my brother and I were at.
On a day-to-day basis, I'm sure there's still, I don't want to say gnawing at you, but obviously it's still the security and the financial aspect is still a concern. How do you deal with that, or how have you kind of come to terms with that?
Well, converting from an insurance-based practice with having revenue coming in every week, and and you have expenses to meet. There's a certain amount of security with that, but when you do convert to a direct primary care practice or any type of direct pay model, there's going to be a disruption in your cash flow. I think it's timing of when you make the change. If you know that you're going to make the change and you give your patients enough time to react to the change, research it, you can still see patients right up to the very end before you make the conversion, and that's exactly what we did. And because insurance companies in general delay making payments to doctors and hospitals, sometimes anywhere from 30 days to 90 days after the services was rendered, we had cash flow coming in, for 2 to 3 months after we make the conversion, as we were getting our patients signed up in the direct primary care model. If you can hit your target number from an established practice standpoint, you're going to do fairly well. You're going to be rewarded fair for what you're doing, and cash flow shouldn't be an issue because you're charging the patients either on credit card or auto charge, or they're paying you prepay for the year or what have you. You have that money right up front, and it's recurrent every month. There's no fighting with insurance companies with the proper coding. They didn't like the paperwork that was submitted and all the different things that are the roadblocks to getting paid. With the direct pay model, you're getting paid once a month at the same time every month, and that money's there. And your expenses our expenses actually dropped significantly from when we took insurance to going to direct pay. So, just the operating expenses went down significantly, and that showed us how much administrative costs were being added to the cost of running a medical practice. So,
do you have an idea how much it went down by? Like a rough number?
Yeah, based on our numbers, our expenses have dropped $100,000 from last year, and that was the common denominator. We still have the same number of staff. We have 2 full-time employees and 1 part-time, and we've maintained that same staff even post-conversion. And so the payroll aspect is still the same that way. We've made some changes with our malpractice insurance. We don't have to pay our third-party billing company to recover claims. So that was a big standpoint of it. And I think a lot of the people out there, they don't understand how complicated it is just to try to get paid by the insurance company. Yet everybody pays their premiums to the insurance companies every month. If they didn't pay them, the insurance companies would send them a warning letter, then drop them. Unfortunately, on our side of it, trying to get paid is a whole nother, it's an obstacle course. And it shouldn't be this complicated. If it wasn't so complicated, your overhead would be less, and you wouldn't necessarily wouldn't mind taking insurance. but you still can't offset for the cost of doing business like any other company. If the costs go up by 10% in a given year, you should be able to adjust your cost of goods sold by 10% to maintain a profit margin. But unfortunately, there's no way to do that when you accept insurance. You have to accept the negotiated rate. And that, unfortunately, one insurance company was paying us at 2009 Medicare rates. I mean, I can't buy a gallon of gas at 2009 prices, let alone a gallon of milk or buy another car. But unfortunately, we're getting paid at 2009 rates by some of these insurance folks, and it's really just not fair or just. So I think, looking at overall reductions in expenses and looking at quality time with your patients and monthly recurring revenue that is predictable, it starts to make more and more sense.
And I think in a lot of ways it feels more secure, certainly where you're at that point where you have recurring revenue that's covering all your overhead and expenses.
Correct.
And paying you a decent salary.
Yeah, I mean, right now with where we're at, I mean, we're covering our expenses. We're taking a paycheck. Now, granted, I'm not making what I made taking insurance, but I know that once we get to our full capacity, 600 patients each. I mean, my brother and I will be making again what we think is fair salary for a primary care physician who is taking care of their patients with diligence and compassion and empathy, and we do it right, and I think as professionals we should be compensated for doing a good job for our patients, and we should be in charge of that. And if the patients don't feel that we're doing a good job for them, then they would have to let us go. I mean, that's how the free market works. But when you take insurance, it doesn't matter. You just got to take these folks and you have to see them, and you're being graded on quality scores. And they'll say, well, if you hit your quality blue points, you're going to get an extra $3 per visit. Well, whoop-de-doo. What am I going to do with $3? You know what I mean? So I think, unfortunately, it's not that doctors are greedy. I think doctors are desperate. And when I mean doctors, I'm referring usually to like your primary care doctors, your pediatricians, your family physicians, your internal medicine docs. We're the lowest paid in the food chain of medicine. And there really hasn't been any good dialogue out there with the RUC committee on how to really offset that. And unfortunately, Medicare, they work on budget neutrality. So they're not going to take it from somewhere else to give to primary care without taking it from cardiology or from gastroenterology, neurology, what have you. They're trying to maintain a neutral budget. So unfortunately, primary care has been devalued for a very long time, and this is a way to bring the value back, bring the relationship back, and feel good about what you're doing as a physician and as a mentor to other medical students who are thinking about making that hard choice. Do I go into primary care or do I go into a specialty? And what they're doing is they're looking at their debt load. They're looking at how long it's going to take them to get out of debt in order to be secure financially or financially free and plan on retirement someday. I mean, I'm 41 years old, and my student loan debt is about $5,000 less than it was after I graduated. I mean, I'll be 68 years old when I make my last student loan payment. I can't be Medicare age paying student loan payments. It just doesn't make any sense. So you can see why medical students are very nervous about the choice, but what specialty they pick. But if we can show them direct primary care as a viable model, we can show them that they can pick that, they can do fair, they can get out of debt, and they can take care of patients the way they always dreamed of. And that's really getting back to, again, that old-fashioned country doc mentality.
Yeah, I have a friend of mine that is finishing up his last year of med school and was between family medicine and orthopedics.
Oh.
And is going into orthopedics for
Sure.
a lot of the reasons you just said, and it's not... A lot of it has to do with other things he wants in his life, like he'd like to have a family and do those kinds of things. And economically, when he sat down and looked at it, it just didn't seem very feasible to do that as a family medicine doctor.
He's thinking like a lot of medical students across the country. And I talk to him, I get emails from students from all over, and their biggest thing is they're excited about the idea of direct primary care, obviously coming out of medical school, going through a 3-year family medicine residency program, and not having a patient base right out of residency and starting direct primary care would be it's going to be a little bit of a challenge. When you're converting a practice, like for example, we had about 3,500 patients between the two of us. we had an audience already who knew us. They knew our style. They knew the way we cared for them. So when we pitched this to them, that we were making this conversion, we could at least retain a portion of that, which was right around 15% of our patient population stayed on with us. So the obstacle for that resident coming out saying, I don't have any patients to really pull from, starting that practice. And 600 patients isn't very many. So, but where do you get them from? I think that's the whole process of how do you start the process of getting patients interested in the direct primary care and then appealing to them and marketing yourself properly. But that's going to be the big risk point for a resident coming out. And there's a couple out in Rhode Island who's actually going to be launching their direct primary care practice, I think, later this month, that I've talked to a few times. And so they've set up a website prior to. They got the word out there, and they're having patients enroll prior to them launching. So that's actually a great idea to help hedge that risk.
Yes, that was going to be my next question. You said you have 800 patients now, and you had about 600 convert with you from your existing practice to DPC?
500 patients came from us. From out of 3,500, 500 stayed on with us, which shows you that 85% of the people didn't like the idea. People feel oftentimes they feel like they're paying twice. They're paying for their health insurance, and now you're asking them to pay a monthly fee to have you as their doctor, so they feel like they're paying twice. And I explain to a lot of folks because, really we're in the advent and transition into high deductible insurance. I mean, unfortunately, some of these plans are, $4,000 or $5,000 per individual or $10,000 for a family. Their insurance, in essence, will not pay anything out until they reach their deductible. So for us, we're in a way, we're almost, with the lack of a better word, really, where they're self-insuring against their deductible by picking a direct primary care practice. So it actually starts to make more sense if you start to work it out. But we know that people in general, if they don't understand something right out of the gates, they're not going to like it. So we have a big job educating the public on the direct primary care.
Let's walk through that, because I hear that all the time, and even I have friends that I try and explain it to, and I have not been terribly successful so far. So let's say I'm a patient that's interested in the practice but doesn't really get it. How do you explain it to someone like that?
First thing we would ask them would be like, do you have insurance? And most of our patients still have insurance. Probably, I would say less than 5% of our patients are uninsured, but most are underinsured. So those folks that have a high deductible, we explain to them that if they have insurance and they have high deductible, that anytime that they seek medical care, that they will have to pay, number one, their copay when they're being seen. Number two, when their claim is submitted to the insurance company would say the deductible is not met, bill the patient. So in essence, they are paying twice. They're paying for their insurance, but they're paying their deductible component. So we tell them that saying when they come in with a direct primary care practice, there's no copays. There's no deductibles. You can be seen as often as you need. And in addition to, we also have our own in-house pharmacy, and we sell all of our medications at wholesale. We'll ask them how many medications they're on. So if maybe someone's on, say, 4 medications and they're paying $20 copay per medication, they're paying $80 a month. So let's say it's $240 for a 90-day prescription. We will run them a quote through our pharmacy on their medications. And what they'll find is that maybe we can fill those 4 medications for, say, $12 for 90 days. So the instant savings that's there, they actually reallocate part of that savings back into being a member in the practice. So in essence, a lot of folks will end up making money on the deal. The next thing we'll tell them is that we have a direct purchasing agreement with Quest Diagnostics. We can buy all our labs through them at wholesale price. So when folks have high deductible, if they get a complete blood count, comprehensive metabolic panel, lipid profile, hemoglobin A1C for their diabetes, that probably would be close to probably $400 in blood work. But through our program, they're probably talking between $20 and $40 for that blood work.
And so if they filed that with their insurance, they're going to be below their deductible. They're going to pay it out of pocket anyway.
Correct. So anytime that they utilize their insurance or use their insurance for billing, that dollar amount will be applied to deductible, and that means that the lab will send them a bill for that amount owed. So we can save them money that way too. So we're getting this blood work at wholesale prices, and we pass that directly on to our patients. So the diet, for example, my diabetic patients that get their A1Cs every 3 months, one guy was telling me he was paying roughly around $75 was his out-of-pocket, and he has insurance. But through our program, he's paying $7.80 for his A1C every 3 months. So again, it becomes more cost-effective. You start working it out and saying, hey, this is actually going to save me money. The third thing is imaging. So, if a patient comes in and they need to get an x-ray of their knee or their ankle or what have you, if they went to go to an imaging center and the imaging center bills their insurance, they will get a bill for the deductible component for the technical part of the x-ray and then the professional read from the radiologist. Through our program, we can purchase those imaging studies directly from the imaging center, again, more at like a wholesale price. So, for example, an x-ray through our program would be $55. With insurance, they're probably looking around between $200 and $300 for that x-ray. An MRI, roughly, is about $1,300 to $1,500, applied to deductible. Through our program, depending on which imaging center we use, it can be anywhere between $300 and $500. So there's instant savings for patients right off the bat when they use a direct primary care practice. We can show them that because we don't have an insurance contract, we're able to purchase medications, labs, and imaging, all because the concept of restraint of trade doesn't apply to us because we don't have an insurance contract. And that's one of the things that makes it a very cost-effective solution for patients who know they have their high-deductible plans and they're not going to be able to get the things they need because they're actually going to be afraid to go to see the doctor because they know when they go they're going to get a bill. And so we can help them with reducing that cost, and they can feel comfortable and confident with coming to see their doctor routinely or as needed for their care. And the other argument people will sometimes bring up, well, I only see the doctor once a year. I come in for my physical. And it seems like it would be an awful expensive amount to pay for the year if I only come in once a year. Well, it's just like car insurance. You pay for car insurance every month, and how often do you wreck your car? You try not to, but at the same time, you're paying for something that's there when you need it. We're like AAA of healthcare, and we're the Sam's Club or Costco of healthcare. You have the membership and you get the discounts. And whether you come in, 5 times, you come in twice or once, it makes sense that what they're paying for is access and availability. And that's which I think is brilliant. It really gives us a chance to do the right thing for patients.
And the contracts you have with Quest and the imaging, was that something, did you just call those people up and negotiate cash rates?
Yeah, that was basically what we did. And I know I got a lot of help from Dr. Umber out in Wichita at Atlas MD. He kind of get me pushed in the right direction. And all I had to do is just contact our representatives at each of those institutions and explain that, we don't have an insurance contract, that we are looking to set up a direct purchasing agreement. And, they said, okay, well, let's look into this. We went back and forth a few times. They said, yeah, we can definitely do this. This is not a problem. You guys don't have an insurance contract, so they're not in breach of any contract that they have because they're selling to a party that has no insurance contract. So there's no issue with restraint of trade.
Mm-hmm. And if anyone hasn't listened to it, Dr. Josh Ember, who Dr. Izbicki just mentioned, was on episode 1, and he goes into some more detail about some of this as well, and I think he's explained it probably more times than anyone I've talked to, so gives another clear explanation of how to talk to patients about this kind of stuff. The next thing I wanted to ask you, Dr. Izbicki, so you had 500, and in the last year you've added 300 patients. Is that about right?
Yeah, I think I think as of today, we're up to we added 275 patients since September of 2013. So we're averaging roughly around 25 patients per month.
So that's higher than a lot of people I've talked to. Is that word of mouth? Are you doing marketing? How have you managed to add that many new patients?
Well, we actually, social media is how we market. We use Facebook. We started a company page, and we made our announcement about direct primary care back in June of 2013. And Facebook is really a good way to advertise and get the word out there. We also have a Twitter account and LinkedIn. And I do all the social media marketing for the practice myself. And, we just try to put things out there that try to, pull on people's heartstrings, that make them think about what's lacking in their relationship with their current doctor. And again, not just their current doctors, that it's their problem, so to speak, but, they can't fix where they're at. We're trying to fix something. We're trying to get back to a grassroots movement here. And so marketing is probably the biggest thing, because remember, we have to educate the patients out there, the community, and also that direct primary care is actually built into the ACA, so if you have a catastrophic insurance for all those bad things that possibly could happen, whether they happen today or they happen 20 years from now, you have that insurance. And that's much more cost effective because you're not trying to use insurance to pay for routine care. And in fact, when we think about insurance, just the word itself, insurance is a policy that you buy for an unforeseeable situation. But in our country, we're using insurance as a form of payment for predictable care. And especially at the primary care level, people need to come in yearly for their annual wellness exams. If they're diabetics, they're seen every 3 months. If they're hypertensive, they're seen every 4 to 6 months, what have you. And we know people during the sick seasons are going to be sick maybe 2 or 3 times that we're going to see them. So it's not even insurance anymore because this is foreseeable. I can predict what my numbers are going to be like and who's going to need to be seen. So, in essence, I had this. You may appreciate this situation. I was in a local hardware store here, and I've had a few odds and ends. And what happened was one of the guys in front of me was complaining about his doctor. He waited 3 weeks to get in. He waited an hour to see the doctor, and he got a 10-minute appointment. And he felt he was kind of brushed off. And the clerk said, geez, why don't you go check out those doctors on Peach Street? They're doing that new thing. Well, we're the practice on Peach Street. I knew exactly what she was referring to, and so I sat down one of the doctors. And then she says, well, I have insurance, and that really wouldn't work for me. And I said, well, here. I said, let me square up with you, and we'll talk about it. So she rang up my order, and I gave her my American Express card. And she went to swipe it, and she says, oh, sir, I'm very sorry. She's like, we don't take American Express. And I said, should I be offended that you don't take my American Express card? And she goes, oh, no. And she started backpedaling really quick and says, I'm really sorry. I'm like, no apologies. I understand. Here's my Visa card. Not a problem. I said, but yet you're offended that I don't take your health insurance. And she said, kind of. And I said, but why don't you take American Express? And she's like, well, the fees are too high. I said, exactly. I said, the fees of taking health insurance are too high on private practices. So, and besides, if this $30 order that I have here in your cost is, say, $18, American Express says it's only worth $5, and you have to accept that as being payment in full. She's like, we'd be out of business. I said, exactly. And so I think that really stuck with a few people I was talking to. It was something they could actually grasp. They could get it. It made sense to them. And I think that's another good example of, why doctors' offices that are moving away from insurance are trying to find a better way to do it that's more cost-effective for them, but it also gives, patients more control over the care. Patients pick us because they want to have a relationship. They're in charge. It's their choice. And we can have a relationship where we can grow old with our patients. And that's exactly what I expected when I got accepted to medical school back in 1997. I wanted to be a general practice doc, and I wanted to grow old with my patients. And I wanted to do a good job for them, and I wanted to grow old with their family and go through our first blood pressure medications together and all those different things that we go through as family docs. So, again, getting back to the core of really what we need to do in America is get back to having good, solid primary care. We need to revalue that.
Let me take you back to Facebook, because that's something other people have told me. Do you have a particular strategy, or like you always post twice a day, you post certain things? What have you found to actually be most effective?
I think a lot of it just kind of happened by luck. I don't have any marketing background or any type of, degree that way. But when we made the announcement back in June 22nd, I posted something that I thought would sound exciting. People are looking for change. People are very unsettled and uneasy about all the things that are going on in healthcare today, and a lot of them don't even trust their doctors because of everything. So I tried to post something that I thought would get their attention, get them at least looking at it, and that was where it started. And then from there, I've done basically selective advertising, and I try to find, maybe that week, I hear a lot of complaints about people saying stuff like, I've had 4 doctors at one practice in the last 2.5 years because the doctors keep moving on. So my most recent post, and you'll just use this for example, that I have on our Facebook page, Caring Kindly Never Grows Old. And it has a picture of an older person's hand and a younger person's hand holding together. I think we're offering stability in our community. We are looking to grow old with our patients, but also caring kindly. I mean, not just treating patients as numbers, treating them as people. Treat somebody the way I would want my wife treated or my daughter treated. I think that's the key. So I find things that are like that, and I kind of focus on that. The other thing that I use is experience the difference. Come get to know us. Because we know what we're selling and we know what we're offering. And I think once people come to get to know us, they actually like to come back. And I had a patient say to me the other day, "Hey, doc, I don't get to see you. I don't have to see you. I get to see you." You know, she likes to come in to be seen. And so I try to target that type of, I guess, bullet point when I put any type of like little advertising in there. Another one I put was freedom to care. You know, insurance-free, 24/7 doctor access. Insurance-free is hassle-free. So there's less red tape. And that's the key. I mean, we need less red tape. I mean, we need to simplify the whole process of how we care for patients. When I try to put something out there, I usually try something every 2 to 4 weeks to put something new out on Facebook. And we have a nice follower. We've been blessed that we have over 2,000 likes on our page. We have a lot of, it's a combination of patients, fans, friends, you know, and they share what we're doing. And I think I can tell you that looking at where our patients come from, the new patients, those 275 new patients in the last 10 months, they've all, just about 95% or better, have come from Facebook. So for us, that's huge. And, you know, word of mouth, obviously, you know, patients who come in, they share, you know, I told my in-laws about you guys, we need to come in, they need to establish, but again, they run across that, I got to pay twice type of mentality, or I only go in once a year type of thing. And those are the two big arguments I see with a lot of people. But once they start to think it through a little bit and they start to work it out, it's also America. You get what you pay for. And I think, you know, we price this thing. This isn't like elite type pricing. This isn't like 1% of the population pricing. This is for the, as I put in our U.S. News article, I told Alan, the producer, I said, you know, this is like a blue-collar concierge. This is for everyday working people. We have people that work at McDonald's that are part of our practice. We have people who are CEOs of small companies. You know, we have school teachers, firefighters, people from all walks of life in our practice. This isn't selecting for only the wealthy. This is selecting for the everyday average person who's just looking for a better relationship and having good access to a doctor who they can trust.
You said, you pointed out you don't have a background in marketing, but you do have a background in storytelling from something. So it's as good a marketing as I've ever heard someone that claims not to be trained. You said you invite people to come into the practice and meet y'all. Do y'all have you just invite people to come in whenever and you'll have like just a get to know you session, or do y'all do a weekly meeting, or how does that work?
As far as like with patients?
Yeah, if someone's interested but they just want to come in and find out more, how does that?
Sure. What we do is we schedule a meet and greet. So Melinda would get the message, and she does an absolutely wonderful job representing our practice and what we're doing. And she'll set up an appointment, and we'll spend half hour, 45 minutes with a patient, potential prospective patient, and try to answer all their questions, again, and put them at ease. But I think also that first encounter really gives them a flavor for what kind of doctors we are, and more importantly, what kind of people we are. You know, I think that's the key. I think we're passionate people. We have big hearts. We're caring folks. And I think, you know, that's, when I think about people in general, what they're looking from their doctors is they're basically looking for three core things. I think they're looking for compassion, empathy, and the doctor to do the right thing. And I know that's exactly what we give them. And I think in this model, the patients who do select for us, I think they feel exactly the same way about their doctor. They're compassionate about us, they're empathetic about our situation, and they're doing the right thing. You know, so I mean, it's a mutually beneficial situation for both parties. And I know, you know, there's just that initial shock factor when someone says, "Why would you want to join a practice where you have to pay this additional fee?" And when our patients start to sell it to other people, it's beautiful. In fact, I had one guy come in to transfer. He hadn't transferred out. It's been about a year, and he decided he was going to finally transfer. He never signed up with us, but he never transferred his records. And we had, 3 people in the waiting room, and he walked in and was just shocked that we had people in he just can't believe it would be working. And the lady and her 2 kids came out, and she's just like, oh, this is the best thing ever. She's like, I didn't have to pay my co-pays. She's like, I got my kids in the same day. She's like, the doctor took their time and answered all my questions. And she's like, this is wonderful. And she's like, besides, our employer offers us an HSA. They put $1,200 a year into our HSA account, and we use that to pay our monthly fee. And he said, oh, he goes, I can use an HSA to stay. She's like, yeah, and besides the medication, I just got a Z-Pack for the one kid for $3.50. She's like, wow. He's like, that's cheaper than my copay. So he ended up, instead of transferring his records, he signed a contract, and he stayed on. So when the patients start to sell it, and they start to make sense to them from a financial standpoint, and plus, our patients, even our prior patients, I know they miss us. I run across them at Wegmans or Target, and they say, hey, doc, I'm sorry I had to go, but it just really didn't make much sense. You know what? I understand. I know where they're coming from, and things are tough across this country economically. People are struggling. But we also have to look at how we spend our money. I have Netflix. I pay $8 a month. It's unlimited. Do I stay on Netflix for 24 hours a day, 365 and a quarter days a year? No. But it's there when I need it. Again, it's just, we pay for things that we don't always utilize all the time, but it's there when we need it. And that's probably the most important thing, that's what people need to know, is that the doctor is there for them. We're there for them when they need us. They're traveling. And I'll give you one other example. Sorry, I'm so long-winded here. But I had a family that was down in Florida on vacation. And the little girl ended up having what they thought was pink eye. So they emailed me. Say, hey, doc, I think she's got pink eye. What should I do? They said, can you take a picture? I said, open the eyelids up and take a picture, and can you send it? Sure. So they sent it. Within a couple of minutes, I had a picture and bona fide pink eye. So I called them in, antibiotic drop, to our local Walgreens, which was transferred down to Florida then. I saved them their out-of-pocket, out-of-network expense that would have been associated with going to a local urgent care in Florida, because it was out-of-state, it would have been out-of-network, and that total amount would have been applied out-of-pocket to deductible. So I probably saved them $400 in a visit just by doing one technology visit over email. We're saving people money. And boy, what a great thing. I'm caring for people, and I'm doing what I always love to do, and what I was trained to do. And the third thing is, and I'm able to save the money. Wow. What a great thing. That's why I get so excited about direct care. It just makes sense.
When Dr. Josh told me your story, I knew I wanted to talk to you because it has, and you've kind of borne this out in the interview, but it really seems like it has been kind of transformative in your life, not just in your profession.
I agree. Again, it's transformative medicine in a way that makes sense for the doctor and most importantly for the patients. I think once the patients start to see the value that a direct primary care practice can bring, it ends up becoming a no-brainer. But there's a leap. There's a leap to starting a direct primary care practice, and there's a leap from the patient to partner with a direct primary care practice. Sign all my emails, your partners in health. And I believe in that. And, I feel like I'm part of the family. And what a privilege and honor it is to be a family doctor and be a thought leader in this particular area. We know that direct primary care practices are growing exponentially across the country. I've been working with 14 different practices across the U.S. sharing our story. It's great to hear doctors trying to make a difference. They want to do this for the right reason. This is not a movement this is not a greedy move. This is a move that's made out of desperation to avoid being indifferent. It's a move to get back to, and again, a Marcus Welby day of medicine, a way that it should be practiced. So that's what I think this is really all about. And I think direct primary care allows for patient-physician accountability. And I think that's what we need today with people. It's a transparent system. People know what they're going to pay. They know that what they can save. There's no guessing. So that's what I think is nice too.
Let me take you in a little different direction here. This is something I've wondered but haven't heard anyone talk to. You're a doctor of osteopathy, is that right?
Yeah, that's correct.
Does that play into your practice at all, or your marketing, or the patients you have?
One of the things, when I was a young kid growing up, my grandfather was a GP, and he was a doctor of osteopathic medicine. And there was one time I had a headache, and he saw me, struggling a little bit, and asked me what was wrong. And I told him I had a headache. He told me to lay down. He did a neck adjustment on me, and I said, "Wow, that's great. How do you do that?" He said, "Well, you have to study hard, and you have to go to school a long time." So for me to be an osteopathic physician, it really was getting the additional training in the manual medicine. I mean, we all, DOs and MDs together, we work together. I mean, it's not like it used to be in the older days. Standard of care is a standard of care. I mean, we both prescribe insulin, antihypertensives, and everything else. But this is one additional piece that we have that makes us a little bit more unique, that we can take care of the whole patient, body, mind, and soul. I think that's a fundamental part of the core curriculum, is talking about the spirituality and talking about those things that are important, connecting with the patient. And I know a lot of and I did an MD residency, and I know a lot of my MD colleagues, they were very interested in a lot of the osteopathic philosophy. And so using that as far as a marketing tool, I guess, into moving forward into the direct primary care, I don't necessarily think that I focused on that very much. I think we've just always believed in just providing, solid care that was relationship-centered, giving people their time. And whether that's MD or DO, I don't think it's really one way or the other. I think it's the philosophy of the physician practicing.
Yeah, I partially wonder, and this is anecdotal and my sample size is pretty small, but I feel like there's, at least from people I've talked to, a higher percentage of DOs than MDs, either in concierge or direct primary care.
I think that, I don't know the answer to that question, to be honest with you. I think I would say that it's probably going to be pretty close neck and neck. I think in general, the problem is that osteopathic medical schools across the country focus on primary care as being one of the caveats to filling the need in the day of shortage of primary care docs. So maybe that is more of the mantra, of osteopathic medical schools. So they want to get their students into primary care medicine. Now, whether the students that say they are going to be primary care actually graduate and become primary care doctors, I guess that would be a statistic I'd be interested in reading. But I think whether it's MD or DO, if you're in primary care, you're feeling the pressure. You're feeling the pressure to see 30, 40 patients a day, fill out all this extraneous Medicare paperwork to get diabetic shoes and everything else, prior authorizations and all that sort of business that goes with it. I think it's not exclusive to either one. I think both sets are dealing with this problem. I mean, so I think direct primary care or concierge then becomes an avenue that you look at saying, how can I get away from all this nonsense and get back to just being a doctor?
Looking back in retrospect, since you've made the transition, what's been the biggest challenge? If you could go back and tell yourself something 12 months ago or 18 months ago, what advice would you give yourself?
I would say don't be disappointed when patients leave. I think that's the hardest part. When I think back to patients when I would get those record requests for transfer out of the practice, people that I've had since maybe I was a resident that had been with me for a decade, it's heartbreaking. You've been through so much with them. You know them. You know their idiosyncrasies. You know everything. You know what makes them tick. You know how to get through to them. And when you see that chart come across your desk to okay the file transfer, it's heart-wrenching. It's kind of like when you played, if you played sports when you were younger, you always remember the games you lost, but you don't always remember the games you win.
Oh, vividly, yeah.
Yeah, so I think the advice I'd probably give to myself or any doctor that's making that transition would say you really can't focus on the games you're losing or the patients that transfer. You have to focus on the patients who believe in you who are staying. I mean, that's where it's at. And then those patients who stay, they're going to share your model. They're going to share why they picked you. And we ask patients to write testimonials, and we put them on our website, just so people that are looking at us from the outside can get a better feel about what kind of care we're giving. And so I think that's probably the hardest thing. It's easy to get very disappointed when you start seeing patients leave, and you almost want to take it personally, like, wow, is this going to work? Or did I make the right decision? But as you sign 10 records of transfer out, you see a family of 3 sign up. And so you got to take the good with the bad, but at the same time you got to count on the numbers that are staying with you or the new signups, and focus on them, because really, again, it doesn't take a lot of patience to make this work. And I think capping your practice is an important part. A lot of people, when I read these different blogs, like on KevinMD.com, I follow a lot of Kevin Fo's stuff, and I can tell you people are nervous because, like, well, what if the doctor gets greedy and they don't want 600 patients, they want 1,000 patients? Well, then they're going to make this much more. Like, well, first of all, if they did that, then their access and availability that they're offering their patients and extended visit times, 30-minute appointments or 1-hour appointments when you need them, you're not going to be able to provide that level of service to those patients. And what they're going to do is they're going to end up leaving you because they're paying for something that they can't get the benefit out of.
Yeah, it's interesting you saying that and what you said earlier about kind of people in healthcare, especially physicians, the way economics works in every other industry, it doesn't work that way in healthcare. You can't, supply and demand doesn't really exist. But if, some physician comes in and brings in more patients than he can provide the level of service for, you can just go next door.
Yeah.
In this model.
Well, and again, you're exactly right. So when patients, in fact, this did happen. I'm actually glad you said this, because more recently, in the last probably month and a half, we've had probably 4 or 5 patients transfer back in after 10 months. And the one guy told me, he said, Doc, he was like, I know now what you're offering. And it just took him 2 or 3 visits with his new doctor that was just down the street to realize that what he got from our practice, even obviously pre-conversion, he knew what we were offering. He's like, I know what my insurance pays for now. It pays for me to wait an hour and they get a 10-minute appointment and I only get 1 problem per visit. Doc, you always gave me the time. You always got me in, and you always dealt with multiple problems during a visit. And I appreciate that, and I know why you're doing this, and I'm behind you 100%, and you signed a contract. So, people start to get it once they, again, they have to go through that growing pains themselves, and hey, we welcome them back because we're glad to have them.
Yeah, I'm going to have to strike, or I'm going to have to cut the part out of the interview where you said you're not a marketer, because the storytelling definitely qualifies you whether you want to or not.
Well, I hope that I'm not boring anybody out there, and that sort of thing, and I hope that I'm trying to just get a clear message out. We know that direct primary care isn't going to work for everybody, but I think it's going to help many. And, but the folks that the message to other folks out there who may be the quick ones to criticize the movement, if you have a doctor you like and your insurance works well for you, then why say something negative against the movement? Because we're helping so many other people with their medications. Medicare patients who are in that Part D program, who hit that donut hole, they have to pay out of pocket for all that medication. It's like, say, $3,000. We can save. So what patients do in those situations is, our Medicare age patients who deserve good care and deserve affordable medication, what they start to do is ration their medication. They start to skip doses because they can't afford it. And so here's the thing. So what happens to their conditions that we're treating, they deteriorate. And when they deteriorate, they end up in an ER. And when they end up in the ER, they get admitted to the hospital. And then when they're in the hospital, bad things happen. They get DVTs, pulmonary embolisms, they get nosocomial infections. So in our program, because the medications are they're pennies on the dollar, our Medicare patients can afford their medications now. And they're on a low fixed income. We get that. So this is a great program for them. It really does help them out. And so we're able to keep them compliant with their medications. We have them in for their routine follow-ups so we can stay ahead of their conditions. And if one of my CHF patients gains 4 pounds of weight within 3 to 4 days and she starts to look at her ankles, she knows to call me. She'll get in that day. She'll get a shot of Lasix in the office. I'll add on some Xeroxilin to her regimen. You know what? And I see her back the next day, and she's down 1.5 pounds. I see her back the next day after that. She's down almost 3 or 4 pounds, and she's feeling better. She's breathing easier. And guess what? I averted a hospitalization that would cost thousands of dollars. There has to be some value from the current system about this kind of care. And so that's what we're passionate about. This is where it makes sense.
So are you opted out of Medicare then if you're seeing Medicare patients?
Correct. We opted out of Medicare. We have no contracts with any commercial payers, no Medicare. So we are completely off the radar that way, which allows us the freedom to care.
Are most of your patients Medicare eligible?
I would say probably, I don't know the number exactly. I would say
ballpark.
I would say maybe probably 5% of our total number are probably are Medicare eligible, but they signed a 2-year contract that basically is per Medicare guidelines, so that keeps them compliant, keeps us out of any trouble, and it works. But I think the Medicare folks are the ones that are going to start talking more and more about the direct primary care because they can see how cost effective the medications are.
Yeah. But the 95% of your patients are under Medicare age.
Correct.
Okay. Well, we're running up on time here. Is there anything you'd like to leave listeners with? Anything you're working on you'd like to let people know about?
I think the message is still just the message. Don't be quick to criticize. Think it through. It is a viable option. It's helping many people. And again, if your situation is that you're happy with your doctor and you're happy with your insurance, we're not anti-insurance. We're just saying that we wish that we could work more in a collaborative with insurance without all the red tape. And I do know that there are insurance companies in the Midwest that are now starting to reimburse patients for their membership fee with a direct primary care practice. They're seeing that it's saving them money because they're not paying out the claims for medications, labs, and imaging on those patients. So I do think that we're going to be partnering down the road, working more in a collaborative with them, but in a situation where it makes more sense. So it's an evolving model. I do know it's here to stay, and it is a viable option for many patients, and it gives people an option to get good quality care. And I think that's the most important thing for us. But if you're happy with what you have, please don't criticize something if it doesn't work for you. But you may be able to share that model with somebody that it may help. So it's a win-win for everybody.
Awesome. And if people want to get in touch with you, they have some more questions. I know we've been going back and forth on Twitter. Is that the best way to get in touch with you?
Yeah, Twitter is always a great way. I mean, our handle is @DrIz, and DOCTORIZ, or they can, they could go to our website, which is www.driz.com. We're like the Dr. Oz, but we're Dr. Iz, and our email addresses are on there. They can reach us on our email or through our Facebook page, which is Izbicki Family Medicine Erie. It's all one word, and it'll populate. So, or they can call our office directly.
And if you call and talk to Melinda, she is a sweetheart. She was really nice when I called in, so tell her I said hello. But Dr. Iz, thank you for your time. We appreciate it. Everyone else, we will talk to you again next week.
Wonderful. Thank you for your time, and I appreciate all the listeners out there and for you taking the time to learn more about our practice.
Hey guys, this is your host, Taylor Pearson. To give you a little background on the show, after seeing my dad and sister, both physicians, struggle to find a good resource for how to transition from their traditional practices, I launched Concierge Medicine Radio to create a resource to help physicians and healthcare professionals launch, run, and grow patient-centered direct pay or concierge practices. If you enjoy the show and want to help us spread the word to other physicians and healthcare professionals, it really helps us out if you'll leave a review on iTunes. I know the iTunes interface is a little clunky to say the least, so we put together a quick guide on how you can leave us a review at conciergemedicineradio.com/review, or you can go to conciergemedicineradio.com and click Spread the Word.
Thanks for joining us today at Concierge Medicine Radio. If you found today's show valuable, we'd love it if you spread the word by leaving us a review on iTunes or sharing it with your friends. To see notes on today's show, please visit us at conciergemedicineradio.com. While you're there, leave us your email to hear about all upcoming episodes.